So we had some good news this week with Tom Key. When Democrats vote, we win. When they don't vote, we lose. And that's what happened in the last election. Most Democrats did not vote. A lot of Democrats did not vote. And of course we lost big time. And of course DeSantis is using that as, well, he won by so much. But really it's because nobody voted. I guess that nobody liked Chris. So anyway, today we have a very special guest, Scott Darius. He's from Florida for Health, Voices for Health, and he looks so young. I don't know. I must be looking older. But he's an executive director of Florida Voices for Health. He graduated from University of Florida College of Law in 2013 and graduated from University of Florida in Political Science in 2010. And he promised my husband tickets to the University of Florida Gators. Anyway, he began his career in health advocacy in 2012 when he was part of Florida Change, which is, I guess, an organization I never heard of it before, where he helped coordinate the statewide campaign for Medicaid expansion. We're still only one of 10 states that have not implemented Medicaid expansion. So I know there's some upcoming meetings, which I'll talk about after Scott's talk. But I didn't want to hold up his talk, and I did want to recognize anybody new to the. Anybody here for the first time or a new member? Wow. So there's so many. I don't know if you want to stand up and tell us a little bit about yourself. Just let us know where you're from and what village you're living in.
My name is Linda Eldino. I'm originally from Buffalo, New York. I've been a lifelong Democrat, and I live in Fernandina.
I'm Debbie Bias. I'm from Pennsylvania, Western PA, which is really red these days. I've been a lifelong Democrat. Worked and volunteered for Congressman John P. Murtha when he was in. And actually, my mother was a 15-year volunteer for him. She went everywhere with him. She's met Joe Biden, Nancy Pelosi, Hillary Clinton, you name it, and she's been there with them. So it runs deep in our family. And my husband is a Teamster.
Who's next?
I'm Eileen Backowitz. Oh, I'm sorry.
Go ahead.
I'm originally Pennsylvania Erie, born in Savannah, and I live over in Cities Grove. And I've also been always a Democratic member, and maybe not as active as I should have been or wanted to be, but never too late.
Hi, I'm Susan Montgomery. I live in the village in Fernandina. From Wisconsin, but I lived in 7 different states. And lifelong Democrat.
Jerry Battaglia, I'm a Navy veteran. My background is public health, and I'm a women's health nurse practitioner and very concerned about the subject today.
Thank you.
Next.
I'm Nancy Stein. I'm also from Pennsylvania, and I'm in Winifred now.
Well, folks, you gotta have some help here. I'm a lady from Pasadena. I'm a former member, but then AAUW and the Democratic Women met at the same time. So we finally finally got smart in AAUW and said, oh, we've got one more thing. I'm Rochelle Newton. I'm originally from Colorado, and I'm in Pine Ridge.
And I'm in Mission Hills, I'm in Rochester, New York. I was raised Republican in rural New York, but I've been a Democrat for 50 years.
My name is Joanne Philwalk. I am from Michigan and Colorado, respectively. I too live in Mission Hills. My pride in joy being a Democrat was I worked on the Barack Obama campaign back in 2000. And my pride and joy is my photograph standing next to the president and an autograph for him.
Hi, everybody. I'm Arlene Kershaw. Originally from Maryland, originally from Arkansas, but we've lived the last 50 years in New Hampshire. And we live in the village of Hillsborough.
Anyone else?
I'm Roxanne Bean. I'm from the red state of Indiana, but I lived in the tiny spot in Bloomington. I'm a lifelong Democrat, and I'm from New Haven.
Was Haven in Connecticut?
Pardon?
Was Haven Connecticut or?
No, I live in Lynn Haven.
Anyone else?
Hi, I'm Teresa. I'm from the Baltimore, Maryland area. I worked as a legislative aide, so I was able to work with federal, state, and local people. And I coordinated and volunteered for many, many campaigns, Democratic. So I live in Lake Teton.
Shelley, you're not new, are you?
I'm just saying hello and welcome, everybody. I'm so delighted to see a room with a tush in every seat. And when I signed up as a founding president to get a room, and the young squirt said to me, well, how much space will you need for 2 Democratic women? And I said, you watch us. And I went to Rohan and said, you need to get rid of this guy because we are all, Democratic Party is the oldest party in the world, not the Republican. So we are loud and we're proud, and thank you for all the new faces.
I'm going to let Scott talk, and then afterwards if we can talk about some of the upcoming events that are coming up. Okay?
I'm going to take Sue with me everywhere to hike me out. She's the best. Wow, guys, thank you so much for having me. What a pleasure to be here with you. I feel a little bit of pressure. I don't know if you guys normally have this many new members at meetings, but I feel like a lot of pressure to keep you guys in. Like, I just hope this presentation doesn't like stink and you guys are like, I'm never coming back. But no, what an absolute pleasure to be here with you guys today. My name is Scott Darius. I'm the Executive Director of Florida Voices for Health. And to share a little bit about who we are, just to start us off. Florida Voices, we're a statewide health advocacy organization, so nonprofit 501c3. Our mission is really to increase access to healthcare for low-income and middle-income Floridians. We do that in a couple of different ways, and typically I describe if our work falls into 2 major buckets, I usually describe the first one as coalition building. But on the drive up here, thinking about it a little bit more, I think it's a little bit closer to relationship building, right? The way our systems are built, specifically our healthcare system, there are a lot of different entities and voices involved. You're talking about, right, stakeholders, health systems, legislators, media, community members. There are a lot of people at play. And I think the way to really think of voices is a group that sits in the middle of all those, building relationships where we can. and then to fundamentally support the biggest thing we do, our priority as an organization, which is connecting to people who have lived experiences when it comes to the healthcare system. So people who are impacted in one way or another by all of the deficiencies that exist. We try to give those people voice. We try to create spaces where they can come in and share their own stories, either directly to legislators or in different media opportunities, or just with their community members. It's fundamentally getting people to understand that they have a voice, they have a story, regardless of who you are and where you're from, and that there are other people who can benefit from hearing it. And so that's who we are as voices, and maybe the longest version of an intro I've ever given. Our issues, just the things we focus on, and we'll get through it as we go through, but strengthening Florida Medicaid, we work to increase access to oral health, and a world we've stepped into more recently in the last year or so, increasing access to supports and services for Floridians with disabilities. And then always protecting Florida healthcare consumers. So, as you all know, the healthcare system is kind of a big mess, right? And there are a lot of things to talk about, so thinking about how to frame and package this presentation today was tricky, because it's like, how do you get to the meat of it without covering everything? And so it feels like maybe the best way to do it, in a time, based on what's timely, is the legislative session, which you all might know started a couple of weeks ago, January 8th. It goes on for 60 days, and so we'll end March 8th. And so yeah, we'll talk about, it actually also happens to be the first legislative session in a while where healthcare is the major focus. So we'll talk a little bit about what's happening. We'll first kind of set the stage, right? Like a perspective on what's happening in the state, and then we'll dive into the bill that's moving its way through the legislature now, which focuses all on healthcare. And then we'll talk a little bit about Florida Voice's priorities and then opportunities to get involved. But as we think about the landscape, I usually just dive in with stats and figures, but no one cares what I think in terms of, you guys are nice enough to listen to me, but the powers that be, right? No one cares what Scott thinks the landscape looks like. It's whoever's in charge gets to kind of decide what that framing is, right? And Senate President Kathleen Passidomo, Republican from the Naples area, Naples-Fort Myers, her big initiative this year was living healthy. Last year, I think it was live local, and this year it's healthcare. But it matters how you think about it, right? Like how you think of what the problems are. That drives typically what solutions you suggest. And you can see here that although, and to give credit, right, in some of the bills that have come out, they hit on points that are a little more universal, that show a little bit more of the breadth, that touch on some of the things that I'll touch on. But you can see here that a lot of what's driving her perspective on it is definitely this idea that people don't have access to elective surgeries. That there are plenty of people that the main problem is that there aren't enough providers for a specific part of the population. And while that's true, I think it's fair enough to bring it up as an issue. I don't think it's maybe some of the most pressing things happening in the state currently. We'll come back to it, don't worry. Thinking about the landscape overall, just looking at a couple high-level things. In terms of coverage and costs, we're still the 4th highest when it comes to uninsured population in the country. And it's probably tied to the fact that we're also one of the more expensive states when it comes to healthcare. 4th most expensive in the country. And when we talk about health insurance, we're also thrilled to have it from our employers. But oftentimes, I say oftentimes, even if you do have it, if you're in Florida, you're paying the highest average monthly premium for your employer-sponsored health insurance. And I think you see that cost factor play out. We worked with the Robert Wood Johnson Foundation early last year, and they ran a survey throughout the state and found that 4 in 10 Floridians were having trouble accessing the healthcare that they need. So we're either skipping care or making other sacrifices to stay healthy. I'd like to start here too, when it comes to outcomes, right? You can see that Florida is lagging behind when you look at the average of the state overall. We're still lagging behind the country in a couple of areas. So premature death and the number of poor or fair health days and low birth weight. You can see those things start to play out, but I like to also show this map. State averages, big averages, can tend to hide what's happening underneath, right? And so when you look at kind of this county by county layout, and this is the state's health outcomes kind of ranked 1 through 67, all counties. So those counties ranked against each other. But you can start to see that there are disparities in some areas. And you can even see northern part, more rural parts of the state where you start to see poorer health outcomes. But even in these places that are mostly like white or clear, so people, another side story, people from Miami always find a way to tell you that they're from Miami. So this is me telling you that I'm from Miami. That's all I got. There we go. But even in Miami, I can tell you that I can name 4 or 5 neighborhoods right off the bat, right, where I know that the clear picture doesn't reflect how poor outcomes are in those neighborhoods. So it's really just to shine a light on that even when you look at high-level numbers that maybe don't look as bad, it's as you start to dive deeper, you really start to appreciate the disparities that exist. And so, looking at a couple different cross-sections, right? Let's start with rural Florida. We know that COVID took a major hit on a lot of these communities where we saw the highest number of deaths. We've begun doing a lot of work in rural areas as Florida Voices for Health. And it shouldn't surprise anyone that you have half as many dental providers, you have half as many primary care providers, and to think about the number of hospitals that have closed in rural areas in Florida. I don't see or hear a lot about it, but since 2020, March 2020, which you all might remember for one reason or another, pretty scary time, that's when you had 3 hospitals closed in rural Florida. I think it was Shands Live Oak, Shands Lakeshore, and Shands Stark. All closed at the height of a pandemic. And so you can imagine what that meant for those communities. Since then, over the last few months, as Voices, we've gone into a couple of those counties where hospitals have closed and got to meet a lot of people and talk about, right, like how that's played out. And some of that will come up a little bit later. But then it's always worth talking about what's happening in communities of color as we think and talk about disparities. We know from Florida Department of Health data, when they actually release data, it happens. That it's communities of color that suffer higher rates of chronic illnesses and poorer outcomes from all of those things that are listed here. We also know that half the people who are in what we call the coverage gap, which again I'll dive into a little bit later, are made up of people from communities of color. And finally, the maternal mortality rate. And I know we have someone who's very interested in that topic here, so it's really excited to see you. The rate for Florida is 28.7. And you see for Hispanic women that it's 21.8. And yeah, don't let that deceive you. I think even that's really high. But for Black women in the state, the number of deaths per 100,000 people is 75.1, when the state average is 28. So you can see what's dragging that number up so high. As we think about oral health, now I'll dive into just like a couple of different categories within healthcare itself. But oral health is another place where we struggle. We have 6 million Floridians who are living in areas that we consider to be dental provider shortage areas. And that plays out in a lot of different ways. It has a lot of different impacts. For kids, 1.7 million of them, and we have, I think, about 3 million enrolled in our Medicaid program. So you have just a huge proportion of them that never even get to a dentist. And that's for a number of reasons, but I think provider availability is at the top of that list. And that shows up for Medicaid enrollees overall, even among adults. And the thing to say about adults, and maybe this will save me a little time later in the presentation, is that in the state of Florida, if you're an adult enrolled in Medicaid, your dental benefit is basically they'll pull your teeth. You don't get any preventative care or anything like that. It's just you show up to an emergency room, they'll pull your teeth, give you a couple of opioids, and send you on your way. And the cost of doing business that way. If we're talking about efficiency and fiscal responsibility, then it's like there's got to be a better, more efficient way to spend some of this money. Instead, we spend it in emergency rooms, where in 2021, which is the latest data we have, it was $500 million that was charged in emergency rooms for preventable dental incidents, right? So it's just it's a lot of money, guys. Thinking about Floridians with disabilities, we as a state, our proportion of people with a disability is slightly higher than the national average. And while luckily most folks qualify for, if you have a recognized disability, you qualify for Medicaid in the state, you get health care. But we know that so much about living a full and complete life, if you happen to have a disability or a special need, it's about having supports and services that keep you in your home and out of institutions, primarily. And our program, when it comes to that provides home and community-based services, It's called the iBudget waiver. And currently we have a wait list of about 22,000 people on that list. The thing is, year after year, that number stays at 22,000, and it's really easy to think that, oh, it's 22,000, so it's not getting much worse, when really I think what's happening is kind of a game of attrition, right? Like, you have folks who are falling off, folks who are dying, for lack of a better word, and then you have, folks who just take themselves off the list for whatever reason, and then folks rejoining the list year after year. And so, it's been a problem for a long time. They say, the minimum average wait is like 7 years. I guess the minimum wait is 7 years. The average wait is actually a lot longer than that. We work with one of our great partners is an 18-year-old advocate, him and his mom, JJ Holmes, and what is he, 19 years old now? So he's been on the wait list for at least 16 of these years and still waiting to get off of it. And it shouldn't surprise anyone, because we're also 49th in funding when it comes to disabilities access. Lastly, mental health. Just to say a word here that I think we all know the stress we've come out of, or still coming out of over the last few years, and as a society haven't really recovered. I think we see this especially in kids. 1 in 6 between 12 and 17 experienced a major depressive episode, right? And 60% of those kids didn't get treatment. We know that in Florida, the 750,000 of adults who who needed some mental health care, half of them didn't get it because of cost. But again, another area where we're 49th in funding in the country, so maybe doesn't come as that big of a surprise. But like I said, no one cares what Scott has to say about this stuff, right? Like, I don't get to drive the agenda. So really, going into this legislative session, Senator Passidomo, her whole thing was live healthy. And it really centers around 2 main policies, SB 7016 and 7018. 16 is where the bulk of it is. 18, just to kind of get it out of the way, is really, it's to start basically a committee that runs a loan program. So for entities that come up with innovative healthcare solutions who want to apply for a loan, a low interest loan from the state, they can go get that money and roll out whatever idea it is. Not a terrible thing. It's just, again, we have a lot of real needs in the state, right? And I think that sentiment is true of 7016, and we'll dive into some of the elements of it. A lot of good things, a lot of things that will have some impact and will help people down the line, but will it help those who are the neediest, and will it help them today? Just to plant those seeds with you. But 7016 really focuses on the workforce, and we know that there's a workforce shortage in a lot of areas, but in healthcare especially, and it does some things to try to increase access to healthcare. Overall, the packages combined, I think the fiscal note came in at 787. And actually, the Senate bills just cleared the Senate earlier this week, so it's very timely. The House bill is working its way through the process, but everything we hear is that the House is very likely just going to take up a bulk of what the Senate is pushing. A lot of the money in there goes to raising Medicaid reimbursement rates, which is a great thing. We know a lot of providers won't engage in Medicaid because of how low they're compensated for the services that they provide. So we're really excited to see that, especially in the area of dental care. I talked a little bit about the low interest loan, and so there's a fair amount of money going into that. It's $50 million a year, I believe, for 10 years, so it's not cheap. And then loan repayment for physicians is a big feature of the bill. But diving into that for a second, as we go through some of the top level elements of it, there's 2 buckets of loan repayment programs. One for kind of just, primary care providers, so doctors, RNs, LPNs, people in those primary care settings, but they've expanded that now to include, folks who are now working as mental health professionals or family therapists and things like that. They're now eligible for loan repayment. I think a positive step forward. And also, there's a dental loan student repayment program, but that was exclusively for dentists, and now they've opened that up to include dental hygienists, but also dentists working in private practices, but the ones that are at least secured in providing care in underserved areas. So again, a good thing. There's money put into a health screening program. So basically, the Florida Department of Health would create a pool of funding, different entities, if they're providing free screenings, health fairs, and things like that, could apply to receive funding, to host those things, and hopefully start to diagnose, right, catch people with preventative screenings a little more often. And then there are some other like stipulations on the Department of Health to make sure they publicize the event and make sure that they're inviting physicians, connecting them to those opportunities, and holding a directory of those events and things for people to at least know that the opportunity exists. There's a fair question to ask about where those people go. If you're the type who had to go to a health fair to get screened, where do you go after someone tells you you have cancer or whatever, or like high blood pressure or whatever it is? Is a fair question to ask, so I'll leave that with you. One of the things we learned from our experience going into these rural communities over the last few months, I'll tell a side story here real quick, if that's okay, Sue. Side story. So I was lucky enough, 10 months ago, my wife gave birth to our first kid. I tell that story mostly for the claps, 60% for the claps, so thank you. But it was, I guess, right, you're going through this thing, and one morning my wife wakes up and she's like, Scott, I'm having contractions, I think we're in it. And my sister, luckily, is an OBGYN, I text her, she says, I think it's time to go. You're right, like the time is such that it's time to go. We get to the hospital and they tell us, right, they're like, okay, well, you're in labor, but also we can't keep you here. And it's like, well, that's crazy, where are we? Yeah, we can't keep you here. Luckily, we live 15 minutes from the hospital, so it's not that big a deal. Our induction date was actually the day after. So they said, hey, call us 4 p.m. the next day, we'll see what we can do. Call them at 4 o'clock, can't take us. They say, call us at 3 o'clock in the morning. Okay, fine. I got a little bit of sleep. One of us had to get sleep. Don't hold it against me. One of us had to get sleep. So, my wife, by the way, is having contractions every 10 minutes at this point. They would range from like 3 to 5 and then from like 10 to 15, depending on what she was doing. But she wasn't sleeping, bottom line. So we wake up at 3 o'clock in the morning, we call the hospital, and they say, well, we can't see you, but we also we're just gonna tell you up front that we might not be able to take you in today at all. That's how long of a line of inductions they had scheduled before they could let anyone in. The short version of it is my wife got upset enough where I think she did like 3 miles around the kitchen island, getting angry enough just to get herself to the point where she was gonna have this baby. So we got in later that day on the 23rd, thankfully. But it was talking to the nurses, you find out that it's because all the hospitals had closed in rural Florida. So there are these people who are driving 2 hours, an hour and a half to get to a hospital to deliver babies, right? And it was hypothetical to me at that point until we went and talked to people in communities and found out that it was all those worst case scenarios that I had imagined was actually just real life for a lot of people. It was actually happening to people who had to drive and found themselves in really difficult positions. So all of that to say, there's a problem. Now, how we're addressing it. One of the things, there are these birth centers that exist, and I guess part of this initiative is expanding the scope of who they're allowed to treat and see. And so now there'll be these birth centers can get the designation of an advanced birth center, where they'll be allowed to do some cesarean deliveries, where they'll also be able to try labor for people who are between 37 and 41 weeks, where I believe that before they had to be at 42. There's some other requirements, like they have to be staffed 24/7, they have to have these 2 medical directors on board, they have to have a surgical suite, and have to be staffed by a registered nurse, at least one present at the center at all times. Now, there's also this other requirement on hospitals where if someone presents themselves in the emergency department and you find out that they don't have a primary care physician and they have other non-emergent needs, the hospital has to have a diversion plan. So they have to be able to tell this individual where to go get help in primary care. Another question I'll leave you with is, if I show up at the hospital, in an emergency room, because something's happening to me and I haven't been able to take care of myself, what are the odds that there's a clinic somewhere that I could have been going to this whole time, or a primary care physician who would have been seeing me this whole time? I'll leave that with you. But that's one of those things. There's also just additional money to increase the number of residency spots. There's a little committee that's meant to review what's happening with our residency program overall, and if we're creating a good pathway for medical residents and medical students into Florida's workforce. How effective that'll be, we'll see. they allowed free clinics to now see folks who earn up to 300% of the poverty level. There's no money associated with that. They're just now allowed to see those folks who make up to that amount without being liable for, without being able to get sued. Right now, if free clinics see anyone up to 200%, they have sovereign immunity, and it's now up to 300%. But doesn't account for, if they start seeing these patients, who pays for that additional strain, especially if they're a free and charitable clinic to begin with. On the maternal minority health piece, one of the things they've rolled out over the last couple of years is this telehealth program where they piloted it in, I believe, 5 counties. And they just use telehealth to try to connect low-income folks to prenatal visits, try to do ongoing education and things like that. And I guess it's been relatively successful, and so there's money in it. Last I checked, it was $29 million a year recurring to run that program statewide. Again, I think there's some questions we'll see in the rollout in terms of, especially in rural communities where access to internet is an actual and serious concern. So we'll see how that goes. The last bit, interstate compacts. So for medical doctors, for audiologists and speech language pathologists, and physical therapists, there are these national compacts, basically, where states will show reciprocity, nailed it, with each other, right, and allow physicians to move across state lines. And so it's, maybe an easy way to kind of lower the barriers for providers in other states to come and practice here in Florida. But you might be wondering, Scott, was there anything in there for health coverage for low-income Floridians? Like, how do they get comprehensive care over time? I can see it on your faces. Senator Pasadomo's answer is no, we don't need Medicaid expansion. He was very forceful about it when the session kicked off a few weeks ago. Just like, no, it's not happening. Don't ask me about expanding Medicaid. This was a quote from before session where it seemed like, well, her idea, and I think we've seen it in some of the funding that's played out, we're going to start doing more with prevention, health fairs and the like. And let me tell you, I went to a health fair once, what you would call maybe a health fair, remote area medical, that once used to provide free care in places like Africa or South America, whatever it is. But then realized how much need there was here in the States, and so came back and started in Appalachia and stuff like that. They came to Florida for the first time, I think 2017, 16, and I sat in a parking lot at Manatee Technical College over on the West Coast, and to see this parking lot fill up overnight, and it was the day before the event. People sleeping in lawn chairs or whatever in their cars for the whole night to try to get care the next day. And to see what it meant to folks to get care in the one setting was awesome. But then you're there the next day, and I talked to a couple of doctors and stuff who I knew there, and the thing that broke their hearts was that these folks are leaving. Like we've seen them once and they're gone, but a lot of these needs were ongoing, and how do you keep people healthy over time? How do you give them a chance to learn the behaviors they need to learn and to get the check-ins that they need, all of those things. So that's just kind of where I fall on the health fairs and the like question. I'll leave you with a couple of these. I think I peppered them in there as we were going through, but thinking about life after the Live Healthy bill. If you're uninsured, and these were questions that were kind of asked by legislators as the bill was being debated a few weeks ago. But if you're uninsured and you're diagnosed with whatever issue after a screening, where do you go? How do you get ongoing care? And how do you afford it? What resources are there for those free and charitable clinics that are now taking on all these patients? All the people who hospitals are referring to and all the people who are being met through the telehealth program and all the other things. And then ultimately, are we spending money in the most efficient way? Like this was an $800 million investment just this year on this program. Will there be some return? I think so, absolutely. Are there other options that maybe spend the money a little bit more efficiently? I think it's worth a debate. So I'll start us off, just to start to wind us down here. Our policy priorities going into legislative session as voices. Access for low-income Floridians, so Medicaid expansion, oral health access, so strengthening our Medicaid program and the adult dental benefits specifically, but then access for people with disabilities. How do we eliminate this wait list and make sure that APD, the Agency for Persons with Disabilities, has the funding that they need over time to continue to provide services at a high level. Now, I usually play a little game here. Maybe you guys already saw it, but let me ask you this. In a family of 3, what do you think the most a parent can make? If you saw it on the screen, you'll just not answer, right? Thanks. But if you're in a family of 3, what do you think the most you can make is and still qualify for Medicaid? So if you're a parent, family of 3, what's the most you can make in a year without losing your Medicaid eligibility?
I think it's 20 grand.
Let's get some answers. 20 grand. 20 grand. That's nice.
It's under 8.
Who said 23?
I don't know.
22.
But it's 22.
22. That's what it is. You guys are just kind-hearted people. That's the problem. You're all too nice. But we have one person here who knew, which is under $8,000 for the year. Yeah, it's shockingly low for a family of 3. It's shockingly low, guys. Yeah, that's what you just have too big a heart, and you're like, oh, 20,000. That sounds reasonable.
From my father when we had to apply.
It's a tough.
It's under 8.
It's a tough business. Yeah.
I had a brother who was uninsured, who had a medical historical operation. He passed 11 years ago. He kept getting sick afterwards and then hospitals, et cetera, said he had no insurance, and finally, I mean, he didn't die because he didn't have insurance, but however, had he had better health care going through what he went through, possibly could have mattered a bit before it got to the astronomically emergency situation.
It's that question.
I want to say, look, I'm blessed. God bless my union from New York City. But I teach here, and I teach at a local college here in Florida, and I have tons of students, and they come in with all kinds of stories. What I didn't hear is a couple of things. I didn't hear anything about the wonderful bill for women's reproductive health.
The ballot initiative, or
to possibly get this abortion ban from a man who couldn't get pregnant if he tried. And the other issue is telehealth is very good if they have access. I mean, I have virtual visits with umpteen specialists, but I'm very fortunate. But if you don't have a phone that connects to an internet and you don't have use of technology, unless you go to a public library and can actually have access to that, telehealth is useless because you can't see your provider. So there are so many, Florida sucks, man. I mean, the fact that they won't take free federal money because you don't like who gave it to you is abuse.
But they take it in every other way too, is the thing. Yeah, like our budget is mostly made up of that. Mostly made up of like federal dollars. So it's not like they're allergic to it. No, they love it. They just don't like when there's credit being assigned to whoever. So, but I also will get back to the reproductive health question because I think that's a really important moment, and so happy that they made it onto the ballot. Very good friends of ours who are working in that space. And we have our Medicaid expansion ballot initiative that's coming up too. So you all get the point of like Medicaid expansion and how much money it would cost the, save the state. Yeah, actually, we can just cut right out of here. Let's do it.
So an argument against Medicaid expansion is that if Medicaid were expanded, it would make it even more difficult for the existing Medicaid patients to get care. So has that been the situation in other states, and how do you respond to that, aside from hiring more doctors?
Yeah. So I will say, right, like just being objective, that Medicaid expansion on its own isn't going to fix everything. That like the Medicaid system itself could be stronger in a lot of different ways. And I think what you've seen other states do is well, first of all, we're one of the last 10 states to expand. So we've seen the experiment play out 40 other times and can draw pretty strong conclusions about what it might mean for Florida. One of those things is that it would save us $200 million a year, and that's not like conjecture, it's based off of what everyone else has done and kind of creating efficiencies in our system. Now, with the money that other states have saved, they've reinvested that, right, into higher reimbursement rates to attract more doctors. But then there's also other things we can do, like lowering some of the barriers to enrolling as a Medicaid provider in the first place. Like, it's a complete, to navigate the bureaucracy of becoming a provider in Medicaid, it's a lot. And some people, it's not worth doing on its own, even if the reimbursement rates were totally even. So I think there are a lot of other tweaks, right, that you have to do, not just giving people a ticket in the door, but to like strengthen the program overall. What we can't ignore is that the way we've created, the system we've all created and have lived in, not we all, but the system we've created suggests that, not suggests, but demands that you have to have health insurance to get in the door. You have to have a ticket to get in, and without that ticket, yeah, well, what are you left with? So I appreciate when people bring up the other parts of the system that need to get fixed, because I love having that conversation. It's just when there are a lot of folks who don't want to engage on the part where you also give people access to coverage. So yeah, I really appreciate that question. Yeah.
Going back to the reproductive freedom issue, one of the things I read recently is that in states that don't have a state bill or it's not embedded in the Constitution, a lot of doctors are leaving the states where abortion is not allowed, and that Florida was one of those states. So it seems like, there's an issue here of trying to bring in more doctors when more doctors are going to want to leave because they, it's so restrictive. How do you deal with that?
Yeah, there's that fundamental disconnect, right, between those who are making the rules and the rest of us who are just kind of living life. It's tough to say how it'll wash out, right? Like what the net impact will be one way or the other with some of these things that feel like pools. But then you also have the very real fact of like, yeah, what's happening with reproductive freedom. So we'll see, because we do have it in our Constitution on some level. There's like the personal, I forget what we call it, but the privacy thing that like keeps us as one of those states where we'll have some level of abortion access. But then we also, what we've seen is that the issue made it on the ballot for 2020, this November. And I don't know, I think what the last couple of election cycles have shown me about Florida is even though we'll pick people who are a little, I have to say nonpartisan, but you guys get it. Yeah, even though we'll like vote for whoever, issues-wise, we've always been on the side of like those more progressive things, right? Like we voted for a $15 minimum wage, we voted for rights restoration. We're like, yeah, so it's the people, even if they'll vote for whoever, issue to issue, and we see this on our Medicaid expansion polling too, where it's like 70% support. So that's people on both sides. And so I anticipate, I can't say for sure, but I anticipate that, yeah, when the question is on the ballot, that Floridians will vote to protect it, and hopefully that keeps folks coming here. Yeah, sorry guys. Sue, you have to help me.
Our Rotary Evening Club has a project called Bridge the Gap, and we work with the Lazarus Free Clinic. Awesome. And one of their issues was our doctors are trained to diagnose using diagnostic tests that are very expensive, and Lazarus Free Clinic can't afford to do that. So our little 30-person club is trying to bridge the gap by paying for the MRI or the CAT scan that's needed for this patient whose symptoms may very well present as something that they can't diagnose without the MRI or the CAT scan and be in compliance with their best practices as a physician. So it goes back to your point of it's one thing to have access to the free clinic to go in and get diagnosed, if you can afford to get diagnosed. And it's another to find the care afterwards, but most are not even able to get definitively diagnosed of serious things.
That's such a great point. I don't have much to add to that other than to say I hadn't considered, right, those situations where if you're a small free clinic, right, like I'm part of the Acorn Clinic in Gainesville, but there's some of those bigger things that we can't do because you don't have access to either the machines or like the funding. Anyway, I just really appreciate you making that point. I think it's one that should come up more often. I think we're going to come here and then we'll go back. Yeah.
And and I sell marketplace insurance. And for example, I do more in Wisconsin. And the minimum you can make is $14,000 for one person in the state of Wisconsin to get on marketplace. And down here, that gap, you know, $8,000 to get Medicaid, and that's a big gap. So that means that family can get nothing. Because if you don't make a minimum of a single person at $14,000, you can't get marketplace insurance. And the gap here in Florida is outstanding.
The one thing I'll add is that if you're a single, like if you're just an adult without a dependent child, you don't qualify for Medicaid at all, like regardless of what you make. So yeah, you like have to have a kid in the first place.
Wow.
I'm gonna go here then. I'm gonna go here.
No, wait, just a minute, please.
Oh.
Are you finished with your presentation? While I appreciate the questions, it seems the presentation is going ahead without us.
Yeah.
And if you're not finished,
Oh,
I'd
is
like
it?
to hear the presentation, then if you don't mind.
Yeah.
Would you mind?
Whatever you guys, I'm here, I'm at your service.
I
So
don't
whatever you
want to
need.
miss the presentation.
Yeah.
I appreciate all the questions and the comments. They're really fabulous, but I don't want to miss the presentation.
I hear you.
Thank
Appreciate
you.
that. Yeah. I'll speak, how about this? I'll speak through it and then we'll just get the questions. Okay. We're on it. Oral health. I talked a little bit about the adult dental benefit, right? And so I should mention that we're bringing folks up to Tallahassee every week, people who have stories and lived experiences and providers and the whole thing. We'll be back up there this Tuesday, mostly talking about oral health. And you know, like I mentioned, Medicaid doesn't cover much of anything for adults when it comes to oral health. And so what we're pushing for is this expansion of services. And we actually partnered with the Health Policy Institute at the American Dental Association. And they did an analysis for us, and yeah, we're able to pull numbers on what it would cost. And for the modest investment, right, that you put in, how much we all benefit from it, how much society benefits from it in terms of economic impact and money we save on emergency rooms. I talked again a little bit about our effort to eliminate the wait list. I think there was a lot of money put into it by the Live Healthy bill, so we're just waiting to see how that washes out and what that means for actually addressing the wait list. And they also increased reimbursement rates for providers, specifically those who see individuals with developmental disabilities. So there were good things that happened and things we're excited about. It's just a question of how it comes out in the wash. Finally, just to close this out, a couple different ways to engage. I talked about our trips to Tallahassee. What I would love is to take all of you on a bus one of these days up to Tally and just go knock on a bunch of doors. Because they would learn a lot from everyone in this room. If you're interested ever in coming to Tallahassee with us, we have a sign-up sheet or a form, but you can also just reach out to me personally. We have this grassroots coalition called Healthcare for Florida, led by our advocacy director, Acadia Jacob. We meet once a month, Monday evenings, and just she'll update folks on what's happening on the ground, but also whatever campaigns we have coming up. Finally, our ballot initiative, it's the PAC that's leading it. It's called Florida Decides Healthcare, and it's mostly made up of our same coalition partners that have been working on these issues together for a long time. We're trying to get on the ballot in 2026, which feels far away, but you know how these things go. Yeah, time's always slipping away from us. We'll start collecting ballots, signatures in earnest, beginning February 1st, so 10 days from now, 11 days from now. We have to get right about 1 million, right? The official number is right under 900,000, but we're shooting to collect 1 million, 1.1 million, just for redundancies. And then once we collect a quarter of that number, we'll get to Supreme Court review. Now, you might have heard that the ballot initiative for MedX has been around for a while. There have been a couple of iterations of it. The closest we came was actually right before the pandemic, where we got to the point with mostly a volunteer effort, triggered Supreme Court review. Sure enough, COVID hit, and then the court took like a year off, and then got back to us, I think, 2 months after the election, and was like, oh, well, I guess it doesn't matter anymore, so never mind. And so we're right back kind of at the beginning of that process, but excited that we've built out a real infrastructure for it this time, and I think we can take it all the way. So there are a couple different ways to help. Right, signature collection begins in February. I would hope to engage all of you all in that work. If someone here has $10 million that they're just sitting on, feel free to hit me up. But then, bottom line, for us as an organization, it's always about sharing your story, right? It's how do we connect decision makers who have no idea, somehow they have no idea how the rest of us are living and what people are going through. That's the gap we're trying to close, fundamentally, is giving people a chance to educate lawmakers and build relationships that way. And we've been fortunate to be able to do that in a couple of different settings. So yeah, just stay plugged in, and that's us. I appreciate the time. Awesome, thank you. Good looking out. We're gonna go here.
Very quick comment and a question.
Go for it.
My quick comment is we all know our governor declined billions of dollars from the federal government to fund Medicaid in the state. So thank you for your hard work to fill that gap. Thank you. Question. I've been reading about this new state law that passed in Florida. I guess Florida is the first state to pass it, to allow drugs to come from Canada so that people can afford their medications. I can't find a lot of information on it. Any comments on that?
Only it passed a couple of years ago, right? And that's the thing.
Oh, okay.
Yeah, well, it was a couple of sessions ago where they actually like passed it, but then it had to go through so many like rule making like hoops, and CMS had to approve it, and I think that only happened very recently. So it's one of those things where it might work. I think it could be helpful. I think Canada might have something to say about it, right? Because they don't want people siphoning like their drugs, like they keep affordable. It's like, why don't you guys make your drugs affordable? So I think there's still a question of like how that'll shake out, but it's one of those things that may help.
Yeah, okay,
Yeah.
I just curious. Okay. Thank you.
Aaron.
Yeah, speaking of legislators who have no concept, Daniel Webster, do-nothing congressman from our district. Barbie Hall needs your help in getting on the ballot. Otherwise, there's a tremendous cost for a filing fee. So Barbie Hall is going to be a terrific candidate, and I suggest that you fill in and submit these applications here.
I left those petitions on everybody's chairs, so hopefully you'll sign them if you're a registered voter.
Where do you want to sign?
We'll go here, here, here. We'll go here, here. Okay, so we'll start here.
Regarding the oral health,
Yeah.
I was an emergency nurse, so it's not only the cost of the emergency visit for the oral pain and the broken tooth, but it's to down the road, they need the oral health because of the heart issues and health issues that bad oral health cause. So that needs to be brought up.
No, you're so right. The connection between oral health and overall health. Why, I don't know why they like, why our medical education system is such that they're like so separate from each other, but we know fundamentally that oral health impacts the rest of the body. So I appreciate the shout out. Awesome.
I was actually going to say something very similar, because there are certain health conditions, like if you're diabetic, and I am, but if you're diabetic and oral health is totally important in controlling diabetes, because any kind of infection or inflammation or anything, I mean, if you don't have regular oral care, if you have certain health conditions or heart conditions or diabetes or something, you'll die. And it's the, it's the chicken and egg thing. But for people who really can get health insurance, that gap, and I know from personal experience, that gap is, ridiculous. Because I know people who are denied. They're not making any money, they're not 65, they're in that range, the kids are gone, and they were denied all over the place and couldn't get anything.
That's what stands out, right? Like the system is built on who we think is deserving and who we don't think is deserving. And that's why like pregnant women and children, we'll always have a heart for, and for good reason. But then you get down to adults and it's like, well, nothing for those guys. But the thing is, even if you were taking the most selfish approach, right? Like even if I wanted to be completely self-serving, the best approach would be to, provide care up front so that I'm not paying for it, later through taxes and emergency rooms and supporting local hospitals and stuff like that. So even in the scenario where I'm being extremely selfish, it's still the right thing to do. So I really appreciate that thought. There we go.
Yes, I have a question about how do county health departments function? I saw that in the Panhandle, and they were running about 33 to 35% indigent care, which almost makes them not be able to keep their doors open. I don't see that kind of health care. It was almost everyone I knew went to the county health department because there were so few primaries in that county. I don't see that kind of thing down in this end of the state. Is that just limited to certain, how do they determine which counties get county health departments that serve the public?
So I think every county health department does, right? But they're under such, I think they've been under such strain these last few years that they've had to either pull back completely on services or kind of build relationships with other entities that they try to funnel people to. But I think fundamentally they just don't have a lot of capacity to do much more than some of the screening programs and things that we've seen in terms of like actually providing, right, like constant care, continuous care that people need. I think it's just been a really tight situation for a lot of them. You do have some counties like Hillsborough where they have, where like they've imposed a tax locally and now they have a county health plan and they're able to give individuals like more comprehensive coverage. It's just not every county, I think, that like has kind of the hospital infrastructure and some of the other, the tax base generally, basically, to kind of build that kind of program out. But yeah, I appreciate the shout out for departments of health, for the county health departments, mostly because of the strain they're under. And it's not just like fiscal, it's also political. Like a lot of the fallout from, right, like the beefs over COVID and whatever, even the language we use. So if you're a county health department with limited assets, right, you'd love to be able to deploy that in a way where you're getting to the people who need the help the most. But they're not really allowed to talk about disparities. They're not allowed to use the word, frankly, about disparities and equity and things like that, which, you know, if you can't really address the problem, if you're not saying what the problem is, it becomes a lot harder to do something about it. Also, side note, I really appreciate the shout out for the little old lady from Pasadena. I'm a big fan of Sanford and Son, and it's definitely a punchline, and I'm like, oh my God, it's my friend right here. Okay, great. Yeah.
I think, are you going to join us for lunch?
She's kicking me out.
Thank you, Scott. That was really great. And I'm sure you have lots of other questions, which maybe Scott will talk to you about at lunch. Can I get a hand for how many people are going to lunch?
It's at Bellblade.
Okay, 20. And no, like inside. Inside, very important. So one of my concerns about the abortion ballot, I mean, it was great, we got the signatures, but it still has to go through approval of the ballot wording. It goes through the state Supreme Court and the Attorney General is trying to fight it. So we'll see what's going to happen. There's a webinar, well, not a webinar, you'll be able to see the live courtroom on the web, and I can send out that link for everybody so you can see what they're saying. Because they're not supposed to turn down a ballot initiative if it's not, you know, it's not, the wording is not controversial. You know, it just basically says we don't want the doctor between the government between the doctor and the patient, which is the main part of the. But you know, there's two Supreme Court justices. One is very anti-abortion. One talks about fetuses as humans. You know, so we'll see what's going to happen there. We have a potential issue. Okay, we're going to have we have a couple of new events that are coming up that people wanted to talk about. Deb, you want to? Deb. Okay, Deb.
Dorothy?
Dorothy.
Thank you. On your table is a purple piece of paper, and it's a safe date, March 8th, 2024, at Bridgeport. We're going to start an annual celebration of International Women's Day. A group, Sisters of Suffragists, which is now Sisters of Synergy, is sponsoring this with several other women's groups in the area. And put it on your calendar, invite your friends, and we hope to have a really great turnout. We want to celebrate International Women's Day that's been around since 1910. And the UN has coordinated this, and they have a theme every year. And this year it has to do with women and girls and their eligibility for any kind of computer access and STEM programs for girls especially. So put it on your calendar. We hope to see you there. Bring your friends. Everybody's invited, guys and girls.
Talk about reproductive health. That would be a good thing. Aaron, you had an event that. Did you want to talk about the event you had?
Well, our Rotary Club, Cindy and I are part of that, has a fundraiser for local charities at Wildwood Community Center on February 17th. It's one of these where you have food carts and you have bounce house and you have blood drive and craft sales and whatnot. So any kind of participation would certainly be welcome.
Special
February
charity?
17th.
Can you get a flyer to me and I'll put it out in the
I don't have
my
a
group?
flyer, but maybe
I can send you, when I send out the information about the meeting, I'll send out the Aaron's email address. Okay.
So I already mentioned the Bridge the Gap project that club works on, but it also works on dental care for financially qualified veterans. That they don't have dental care. And so we pay their co-pays, or they only have a $5 copay and we pay the rest. So that's another one of our projects that this fair will go toward, or donations of any sort.
Okay, thank you. We also have giveaways that if you got a ticket, you should get a ticket if you haven't gotten it.